Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone. Uh, I'm happy to be with you today. Uh, and this is a new event trying to start with Viva. And this problem to be exam. Inshallah, I hope this event will help you to start to prepare well for the exam. And if you are going to for the exam in September, this will help you. I also to fine tuning your preparation to get the marks you want and to pass the exam with good marks, inshallah. Our event today will be like a long reporting one, and I'm very happy, really, from the feedbacks of this lecture and this event. Many positive feedbacks come away came away to my account, and my many colleagues recommend further events, pre-events like this one. And I hope that the FRCR tips and tricks group will continue in providing free activities and free talks. And I apologize for redundancy in the last few weeks in making a lot of cases on the group. But we will, inshallah, make this in future better and better, and we will allow our consultants and our colleagues to start with you as well to maximize the benefit from these groups, because you know this FRCR to be exam needs group studies, and it is very helpful in this part of exam. So you need to make this as a routine in your day, to have a subgroups and to have a colleagues to study with them, to have activities within a large groups like this active one, and try to collect informations and tips tricks from everywhere. Today we'll start our talk with a few words and few tips and tricks for Viva. I collect this from Royal College website, as well as our experience in teaching and delivering and helping our colleagues through the different activities. So experience also is very important in this one. I'm sorry, I have some issues with my voice. Um, so after this one, we'll have a simulation exam with one of our candidates. This will simulate the exam exactly. Okay, so you will be you'll see the if you didn't have any exams before and this is your first time to go through the exam, so you'll found a real situation. So we'll have in first 30 minutes maximum, we'll have this Viva orientation. Then we'll start first room in 30 minutes with two examiners, me and Dr. Riham. Then in second room, examiners will be Dr. Rizq and Dr. Muhammad Fuad. And then after we finish this 1 hour of practice with our volunteer candidate, then we'll go through the 30 minutes feedback for his performance, and we'll give him how to adjust the performance for more scores and to avoid any problems in his performance. I hope everyone, inshallah, will enjoy this activity, and we'll start now our presentation quickly. Thank you. Just to adjust the screen. Okay, this is a funky one. I'm trying to make it make it nice, away from the routine one. So I tried to make it little bit in this way. So this is an important tips and tricks, and many of you may hear from me this instructions and these tips and tricks. But if you hear it again, you will hear it with another perspective view. So you'll add in your performance more and more. So you look at you look for this point. This is very important one because this is from the examiner reports and from the Royal College notes about the oral exam and Viva and what they are expecting from the candidates to perform within the room of the exam. As you all know, that we have a structure of the exam of two rooms. First room in 30 minutes with two examiners, and second room 30-minute, two examiners. Very quick one, very quick one. So then you go home. خلاص, you finish the first hour to the exams. So this is the last part of the exam. You'll be assigned to one day between Monday and Friday after the reporting date. Then you'll have this very quick exam in 1 hour. You'll have two sessions of oral exams. Then you go home waiting for the results. So you need to prepare very well because this 1 hour, this 1 hour will have 16 marks of 32 out of 32 marks. So half of the marks of the exam in this 1 hour. So you need to practice more and more and prepare yourself very well for this one. So now we'll take a general look about this important tips. In the exam and during the exam, you will have variable complexity of cases, and this is depending on the examiners and their way to evaluate you. So they have the flexibility to choose whatever the cases that allow them to estimate your performance, and so you will have a very market variability between you and your colleagues and the others. And sometimes you'll have simple cases, sometimes you'll have very complex cases, and this is very variable. So adapt yourself for this one. Okay, your level of performance is expected to be at a higher level. So you will be expected to interpret the cases and the common exam situations and the common and the cases you'll be submitted. You'll expected to perform this very well, and whatever the complexity of the case, they are accepting you or expecting that you are you will perform this at very high level. So to reach this one, you need to be mindset, and you need to play the game as they want. So here is the notes that they want from you. Firstly, they need from you a logical and informed approach. The Viva exam, the main issue in the exam is your approach. And one of the criteria that will make you lose the exam to have a scattergun approach, to have no approach. So you must have an approach for every case, and we'll discuss this together later. So you need to have a logical and informed one. So you are confident about telling this and going through the cases in a specific approach. When you interpreted the image, you need to show your ability to observe the findings and to collect these findings together and to go through the different techniques of the radiology radiology investigations to solve the problem and further investigate the problem in front of you, trying to solve this and get final diagnosis. Examiners also can or may ask you supplementary questions during your activity with them, sometimes to make sure that you are telling this and you mean what you say. or to make sure that you are going through the right path, and to make sure that you have a deep knowledge maybe behind what you are saying. uh, and this is not meaning that you need to prepare the 2A knowledge before you are going to exam, but you must have the the uh, uh, the circle around the cases you are shown. Um, and one important issue that when you are provided by an image or an study, you must reach a conclusion by the end of each one, because each film in the exam have an 8 marks, and each one you need to provide an observations, and you interpret this observation in one, trying to collect this observation in one category and trying to reach a differential diagnosis at least. And if you are going to request any further investigation, you must you must tell the examiner why you are going to choose this one and why you are going to choose it, because this is very important, and this reflects your experience and your knowledge about the steps of radiological examinations, and the steps you are going in during the clinical work and the clinical day, your work. What the steps is very important, not to overcome, not to underestimate any issue like this issue. So you need to show the examiner this all. Uh, Two important notes only regarding this, that during the exam you need to listen to the examiner very carefully, because the examiner many times he will start to guide you by a clinical data. He will start to trying to uh, uh, make you to deviate you to one pathway, and may ask you some important questions. And if you are not listening well, you may lose marks, because the examiner will consider you the hear this one and you neglect it, or you didn't get any information from this one to help you. So please, if you can't hear the examiner very well, ask for clarification. Please ask for clarification if anything the examiner asks or says is unclear. This is very important one, and unfortunately, you may lose the whole marks of one room because this important. One of the important issues, many candidates are asking, how many cases if I did in the exam, or if I make with the examiner, this means that I am going to pass the exam. And here from the Royal College, an important note that allow you to know what is the truth in this issue. The amount of discussion that takes place and the amount of cases shown, it will depend on the examiner himself, and it will be very variable. It will be variable depending on the examiner and the situation in the room. So don't rely on how many cases I did, because if you put this issue in your mind, then you will start to be faster and faster. When you be fast and you are in rush, this will lead that you will may miss findings and important findings, and this issue will affect your marks. And one of the important issues here, you need to know about it before you are going to any exam, the scoring system. Because the scoring system will allow you to know which one you need to target. You need to target in each case in the exam 8 marks. How I can get the 8 marks? You will found it clearly here. Excellent answer means that you have collected all the findings on the film, that you have a good approach in collecting these observations and findings in one manner, and then you are putting a correct and excellent differential diagnosis. Then you go through the management of the patient passively. This will allow you to get 8 marks. And if you go to the opposite side, who will get 4 marks? You will find the opposite. He lost the findings. He missed the findings, even with help. Please localize your. Please, can you comment on the pelvis of the patient? So you go through the pelvis and you are missing the findings. Will be very poor performance and very poor answer. And this definitely will allow you, will lead you to making a dangerous and wrong diagnosis. Between these two scores, there are multiple situations of variability. So you may lose some findings, you may get good or important findings and telling important negatives, and you miss other findings. Then you'll start getting sick. You are telling one differential diagnosis good, you have short list of differential diagnoses, you are putting differential diagnoses are related to each other. So here you start to make lower and lower scores. So your goal is 8 marks. So please, you need to focus on this target. And here, how to focus and to prepare for this one, how to get the 8 marks in each case. Firstly, you need to prepare through this way. You need to observe well. Please keep looking. Keep looking on the film in front of you. Keep looking in your practice, in your preparation. Means that you need to see more and more and more. You need to practice more and more for the Viva exam exactly, especially and for the long as well as we told the last event. So observation is very important, because if you collect all the observations, then you'll get the higher marks in the exam. And your way of thinking, you have an approach. This is an important one, and you will not get this from the space. You will get this from practice. I'm practicing how to make the intestinal obstruction film. So I must go through asking firstly about the level. I must answer this question: where is the level of obstruction? Then I will go to try to analyze the cause of this obstruction. Then I will start talking about the complication of the obstruction. If there is pneumoperitoneum, if there is pneumatosis intestinalis, or there is portal venous gas, or any other issues regarding the intestinal obstruction. I'm going to search for the complications of the cause. Many times the cause have an separate complication. If the obstruction due to a malignant mass, so you are going to search for the metastasis. Okay, so you need to have an approach for every differential diagnosis, and we will learn how to make this one. Okay, so the next one is your knowledge and experience. And here, there is no time in this 1 hour, very short one, to allow the examiner to go deeply through the knowledge of radiology. But if you give the examiner the upper hand, he will start to dive down. So don't give him the upper hand. Means that you need to show yourself by, in the intestinal obstruction case, if you are prepared yourself well, so you are enumerating the causes, and you will remember that the causes will depend on the age of the patient. If you are in a neonatal age group, this will be different from a child age group. It will be different from adult age group. So you are searching for each one about the causes, and then you list this one on the film as positive or negative. Then the examiner will find all the information that he want to test you about it. You told it in your approach, so there is no need for testing your knowledge. Okay, but if you are struggling to search the causes, then he will start to ask direct questions. When he start to ask, you start to get nervous. When you start to get nervous, your performance go down. So please practice more and more. Control the Viva room. Don't let the examiner take the upper hand. And this is will not be except you are confident. And confidence will come if you act your rule very well. You know all the actors will take their rule and start memorize all things before going on a stage. So you are now preparing your rule. So prepare everything before you are on the stage, because you will be in a very serious very serious situation. You need to be prepared very well. And here is a hidden trick, very important one. Many of our colleagues are performing very well when they are providing case by case. When you put a case on the in Telegram group, likely, okay, so they will take the case and will perform very well in one case, but they didn't have an experience to have a 1 hour of cases. This is very different situation, and you will find now in the simulation exam will have it will be tough. Many of the colleagues, their performance after first 15 minutes will go down. Others after 30 minutes it will markedly go down. So uh, you start get confused. You start losing your control on inside the room. So prepare yourself for long time discussion and seeing cases and discussion, and and this you can make it through your colleagues, with your colleagues, your partner. Try to make it longer, because you need to practice, okay, like football players and all this stuff. So you are training because your performance to be at the same level along the whole hour of the examination. Okay, now this is very important. Before you are going to prepare yourself for the exam, you must know the types of the cases are provided in the exam, and every one of these cases is having a different approach for each one. Okay, so we have a four pathways you are going to go through in the exam cases. You may found, don't miss this case. I titled this one like this one. Don't miss this case, because if you miss it, it will give a very bad impression for the examiner, to the examiners about you are. It means that you didn't come today for the exam. You didn't prepare at all. Okay, don't miss this case, the anti-mini case, the rapid reporting case, and I will let you have a samples. If you are provided by looper collapse, so this is a rapid case. So you must pick the abnormality very quick. You must be prepared how you will go through the scenario. Very confident, very quick, very confident. You must be prepared. The intestinal obstruction case in X-ray, uh, the avulsed fracture, slipped capital femoral epiphysis. All of this stuff in the exam case scenario, it's very bad to lose this one. If you are not prepared well for these cases, you must list them and start to prepare a scenario for each one. You must be aware about the findings and how to describe them. In slipped capital femoral epiphysis, I can't see that there is slippage of the femoral epiphysis over the metaphysis, and you must tell the examiner about the complications and about these things. I can see that the femoral epiphysis is normal size, is normal density, there is no features of vascular necrosis. You must know the urgency of the case. So you are going through this is an emergency. I will urgently inform the referring physician about the find. I know that there is contralateral fiction, so I must comment on the contralateral side and go on. So this performance is the expected one in these cases. If you have a double bubble sign and you are struggling to tell what's this mean, and you're struggling to tell the associations of these things, and you are not telling the negatives on the film. So you didn't prepare well for the exam. This is the message that the examiner will have from your performance. So please don't miss this case. Okay. In the opposite side, there will be a challenging case. This is of subtle abnormality, and you will perform this one as in rapid. So in rapid, in the first round, you are collecting the obvious cases and the very easy cases first, and then you'll go through a checklist to be sure there is no abnormality before telling this is normal film. But in the Viva, there is no normal film. All the films are abnormal. So you are from the first look, you didn't get any abnormality. Then you need to go through a checklist to make sure that you are not missing any abnormality. You are showing the examiner that you are a confident consultant. You are showing the examiner that you are going through a systematic approach and trying to solve the problem of the patient. If you have an unclear problem, so you will ask the clinical team about this, your clinician and your colleagues about the clinical issue again. And you'll start to ask about any features or any things that can help you reach the diagnosis. And you are not nervous, you are not feeling unwell inside the room with the examiner. You are confident, you know what you are doing. Okay, you are comparing both sides, especially in the musculoskeletal films. Okay, you are comparing the left femur with the right femur, searching for any subtle change or between the two sides. You are searching for subtle or hidden areas, or even you are listing the differential diagnosis of the subtle abnormalities. So in the chest radiograph, you didn't found any abnormality through the lung field, through the bones, through the soft tissues. So you'll start to go through checklist, and you will remember the list of the cases that may have subtle appearance, like coarctation of aorta, like Swyer-James syndrome, like any peripheral lesion, maybe somewhere. So you'll start look through this. And when you are doing this, you need to be fluent in the talk. Don't go in deep silence. Don't you show the examiner your performance. I'm now checking the right side. I'm now checking the left side. I can't get any abnormality. I am worried about this shadow, but I am not sure. I need to make sure about this one. I want to compare this with the clinical data. And you are trying to reach the problem. At this point, if you didn't find anything, you'll need to go through another approach. I will ask my colleagues. I will try to know deeply about the clinical data of the patients. I will move to another study, okay, for trying to help uh, see the problem. Maybe this is very subtle in X-ray, and I am not sure about it. And even in CT scan, also you need to go through a checklist, and this will be will have in future simulation for these cases. Another type of cases is the obvious finding uh, uh, fell. When you are presented with the CT of the brain and you found a very large mass lesion, a focal lesion in the brain, it's very obvious. Okay, so in the abdomen you have a big mass like this one, this very obvious one. Okay, so why the examiner is they are bringing this kind of cases? Because they need your radiological eye, they need your radiological performance. How you'll go through a radiological your radiological description, trying to narrow the differential diagnosis and reach a final diagnosis by this one. It's an extraaxial lesion or intraaxial lesion. But about the intensity inside, it's a vascular one or a calcification. It's in my routine practice, I will check the other sequences to make sure what about the intensity inside. And we are going through the case trying to use your tools as a radiologist to reach the final diagnosis. And this one is very important. if you don't talk about the mass effect deeply, you are not telling everything deeply, you will not reach the diagnosis. And if you didn't reach the diagnosis, you lose this film. Okay, your next step through the case is very important as well. Another scenario you'll have in the exam is a mini finding film. This one, you'll have a CT scan of chest, abdomen, and pelvis, very large one, and you'll have a multiple abnormalities. Every cut you found an abnormality. So there is no time to describe this deeply as the previous one. You need to enumerate and interpret this one. So you need to collect all the findings systematically. Okay, you got a lot of abnormalities in your first general look. So I got um, many abnormalities. So I will try to organize this all. So I found a pleural effusion here and pleural plaque, pleural nodules, and the nodularity in the pleura. I am now searching. There is absent breast shadow with implant. I'm now going through down. I found these multiple liver lesions and peritoneal disease in form of blah 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 blah. I'm now searching the pelvis. Yes, I can found these bilateral adnexal masses, and now I need to check the bone window and lung window. In bone window, I found this multiple. So you are collecting this all these findings, and then by when you are going through the way, you will discover this. Yes, this is a breast metastasis case. So finished. We finished it. Okay. Some colleagues will go through one lesion and or two lesion and start going deeply, and then they lose the film and lose other findings and missing a lot of findings. They are having uh, they don't have an approach for this such cases. Then they will start lose marks. They didn't get. They didn't talk about bone lesions. Then I'm changing to bone window, and then there's a destructive bony lesion, and this destruction causing invasion to the spinal cord. So he lose marks. Okay, in all these scenarios, don't forget the emergency. Your enemy in Viva exam. Your enemy is the emergency. Before you leave any question, any case, before you leave any station, just remember this one. Emergency. Emergency. If there is any emergency in this case, ask yourself deeply in this one, because this is very, very, very important. So this is the mindset of the exam. So at this point, we are okay. This last one, we are offering in RADME this important one. We are trying to make a special private Viva course to try to help our colleagues to face this issue. We have 5 private Viva exam each candidate will have in our course. This is 5 times in 2 weeks. We are making this in separate days to allow you to have feedbacks and then start to make sure. And this will be before the exam. In our situation for September, it will be between 4 and 17 September. You are private in this one, so you don't have a hot seats one. You are privately private totally with the examiners. You have different expert examiners, so you have a different experience. You have real exam cases. You have 2 options also. Yeah, you can choose 2 rooms with 4 examiners for the 5 exams, or 1 room for 2 rooms with 2 examiners is another option. And you will find this on radme.net in details. And now we will have a simulation for this one. And I'm sorry to make this noise and headache. And I will start to prepare for our simulation. Thank you all, and I hope this is helpful and of benefit. And inshallah, it will lead to more um, when you are going to the exam with mindset, with good mindset. You know what you are going to face. This is very important in your preparation. Now make sure that everyone is here. I'm asking if Dr. Riham with us now. Can you raise your hand, Dr. Riham, please, to make you a co-host?
Yes.
Thank you.
Hello.
Thank you. Hello, Dr. Riham. How are you?
How are you? Fine. Fine.
I'm glad to see you today, and you are with us. Dr. Noha, I think, can you raise your hand, our candidate? Okay, thank you very much, Dr. Noha. Can you raise your hand? Okay.
Yeah, I'm just
Uh,
here.
thank you very much. Okay, Dr. Noha, you are also with us. So we'll start now our first room with 15 minutes. I will set a timer for first round with Dr. Rehan. Then we'll move. I will tell time. Then we will move to another. Me, I will be the second examiner, first room. After we finish first room, we'll move directly to the second room with Dr. Mahmoud Rizq and Dr. Muhammad Fuad. I hope you are ready for this nice one. Okay, Dr. Rehan, are you ready?
Yes, I am.
Okay, so start the timer and Dr. Moha with you. Please, everyone, can you be muted during this activity? Thank you very much. Be quiet. Okay.
Okay, start sharing my screen or
Yes,
just
yes, you can. You can. You can. You are co-host, so you can share your screen definitely.
okay. Okay. So let's go.
Okay.
Okay, this is our first case. First of all, how are you?
I'm good, thanks, Dr. Ham. I'm fine.
Okay, so happy to have you today. Okay, this is our first case. This lady is 45 years old, female patient. We discharge, bilateral discharge.
Okay, so I'm presented with an CC view of both breasts in a female who's presenting with discharge. So background density of the breast is mainly fatty with scattered glandular tissue. I'm just looking at the left breast first. I can see that there is spiculated mass, which is projecting over the lateral side of the breast with areas of calcification. It has a spiculated margin. There are other scattered coarse calcification. I'm just looking at the skin. To me, it looks normal. The nipple looks slightly, perhaps maybe retracted. In my normal practice, I would like to look at the MLO view. Going to the other breast, I can see also just scattered coarse calcification. Nipple appears normal. The skin looks normal as well. I can't see any obvious mass lesion within the other breast. I would like to look at the MLO view just to locate exactly in which quadrant is that mass lesion. I would like to compare to previous mammograms if there is any previous mammograms. I would like to take this forward by performing an ultrasound of the breast as well as ultrasound of the axilla, looking for any evidence of lymph nodes.
Any other thing you would like to add?
Yes, so I would also like to just do a biopsy of that when I'm doing the ultrasound. This patient would require, I assume she came from the clinic, symptomatic clinic.
Okay, fine for this. Okay, this is another case. This patient is admitted with abdominal pain.
Okay, so this is a frontal abdominal radiograph of an adult patient. I can see that there are some dilated central bowel loops within the abdomen. I can see the valvulae convergentis, so this is likely in keeping with dilated small bowel loops, which is in keeping with small bowel obstruction. I'm just having another look. I can see that there is branching lucency projecting over the liver, which is likely in keeping with pneumobilia. I can see that there are multiple calcifications within the right hemiabdomen, right lower abdomen, and there is a calcified density just projecting in at the lower pelvis. So just in summary, I can see dilated small bowel loops with evidence of pneumobilia, and there are there are calcifications within the abdomen. I'm suspecting that this is
Just spot me the calcifications, please.
can you see my arrow?
No, actually.
Let me just request yeah, I'm requesting control. Request
Okay. Yes, okay.
Yeah.
Where is it?
Yeah, so I can see some of them here, but that's just not within the small bowel.
Can you use the cursor?
Sorry?
Can you use the cursor?
Oh, can you not see my cursor?
No, I can't. Still, I can't. But yes.
You can
Okay.
see it now, yes? Okay.
Okay. So
So
yes, you were scrolling the image, but I haven't seen the
yeah, so
calcifications.
can you see? So there are calcifications here within the right lower abdomen. So these, I don't think these are the calculi. There is another calcification just projecting here on the left upper. And there is one here within the lower pelvis. So this is highly suspicious for a gallstone alias. I can't see any evidence of pneumoperitoneum or
Would you like to take it further?
Yes, no evidence of pneumatosis intestinalis. So I would like to take this further by letting the clinician know and suggest a surgical review, as well as doing a CT abdomen pelvis for to demonstrate where is the level of obstruction.
This is another case of 40-year-old female patient with checkup.
Sorry, with abdominal
checkup.
Yes, okay. So I'm just having a quick look. So this is a frontal abdominal radiograph of an adult female patient. I've noted that there is some scoliosis with convexity towards the left. I can see non-specific bowel gas pattern. There is a radiopaque density projecting over the right hemipelvis. I'm just suspicious to me that could it be like a misplaced IUCD? But in my normal practice, I'd like to correlate with the clinical history and see if this patient is known to have an IUCD in situ and just compare to previous images. Just looking else, I can't see any obvious pneumoperitoneum, non-specific bowel gas pattern, but and no pneumatosis intestinalis. So I suspect that.
Okay, fine for now. Okay, this is another case.
Okay.
Just dyspnea.
Dyspnea. Okay, so this is a PA radiograph of an adult patient who presented with dyspnea. I can see that there are median sternotomy wires in situ. I can't see any other lines or tubes or surgical clips anywhere. I can see that there is homogeneous opacification within the lingula and the left lower lobe, obscuring the left heart border. I can also see that there is a quite speculated mass lesion just in the retrocardiac area. Looking at the left hemithorax, just comparing it to the right, there is reduced volume of the left hemithorax. So I'm suspecting that this is a left lower lobe. There is an element of collapse within the left lower lobe, maybe partial.
So you think the pathology notably is at the left?
Yes.
Okay. You can spot any obstructive lesions or something?
Yeah, so I've noted there is a mass lesion just in the retrocardiac. retrocardiac region. So I'm suspecting that this is highly suspicious for a
What do you think about the right hemithorax?
the right hemithorax. I think there. I'm just so this is a PA radiograph. So patient is just looking for any evidence of pneumothorax. I can't see any evidence of pneumothorax. No opacification that I can see. The hilar looks normal to me. Perhaps maybe the right costophrenic angle looks normal. So I'm not seeing anything obvious on the right. So I'm suspecting that this is all just left-sided pathology with a bronchogenic mass causing element of collapse. I'd like to compare to previous images.
Okay, thank you for this. Another case. This is a child, 2-year-old child, pediatric. You can scroll, right?
Yes, I can scroll.
Okay.
Okay, so that I have control, yes. I think
Just complaining of delayed development.
okay, I'm just seeing the images just at the bottom, and I can see like patient data just at the top, so it's not a full screen.
Really? Okay. Just a second, allow me.
Okay.
Mhm. Okay, I think now you can go through it.
Yes. Okay. Okay, so I'm provided with an axial T2 MRI sequences in a child who presented with developmental delay. I am just scrolling through the sequences. So I've noted that there is a markedly enlarged ventricular system, and that's in the form of enlarged lateral ventricle as well as a third ventricle. I'm just going to assess the fourth ventricle looks enlarged as well. Just scrolling back, I can see that.
Any sequence you would like to check?
Yeah, so I'd like to other sequences. So I'm just looking. So there is evidence of hydrocephalus, no evidence of transependymal edema within the provided sequence. So I would, in my normal practice, there is generalized increased extraaxial CSF spaces, more marked on the temporal bone as well as the posterior fossa. So in my normal practice, I would like to check sagittal, if there is any sagittal T1 sequences, just to look for the midline structures and check if there is any
Okay.
sclerosum. So these are sagittal T1 sequences. Again, there is extensively marked dilated ventricular system with thinning of the corpus callosum. There is an enlarged posterior fossa. So I'm just now looking for what would be the cause for the hydrocephalus in this child. So
You have picked an abnormality in hydrocephalus and posterior fossa. Would you like to assess any other sequences? And how would you like to take it further?
okay, so I would like to check other sequences. So I would like to, so I've looked at T2, I've looked at T1. I would like to see if there is any contrast sequences, T1 post-contrast.
Why are you asking for contrast?
Just looking for any evidence of perhaps maybe it's not that helpful in this case because it's a hydrocephalus. So I'm just trying to work out what's the cause of the hydrocephalus.
What could be the cause here for a hydrocephalus?
So in a child, I'd be thinking, could it be like an aqueduct stenosis? So that would be one of the causes. Could it be like a Blake pouch cyst within the posterior fossa, just causing that upstream dilatation of the ventricular system? Other causes.
How would you like to take it further?
So I would like just to correlate with the clinical history and see if there is any previous images compared to previous images. I'd also be thinking, I would like to look at DWI, if there is any like diffusion weighted images. I'd be also checking if there is any evidence of like periventricular calcification. That's in the GRE sequence. I'm thinking of congenital torch infection, like a sequencing of that.
This is the diffusion.
Okay, so on the
Allow me just a second. Okay. Okay. You can go.
okay. So on these are the diffusion weighted. I'm just scrolling through the sequences first before.
Okay. Fine with this case. And share another case. Oops. And I don't know where is the share. Zoom. This case is a kind of an isotope scan, and you can scroll.
Okay.
Can you, or just allow you another time?
Yeah.
Okay.
Just request remote control.
Okay. Fine.
No. Okay, so I'm presented with axial reformatted.
Okay, time.
Thank you. Thank you
Okay.
very much.
Okay, I'll start. Can you, Doctor,
Okay.
allow me stop here, and then I will start my tab. Okay, thank you very much. I'll start to share my screen as well, Doctor. So you need to start with me. Okay, this is my screen. Now you can see it.
Yes, I can.
Okay, and I will allow you to use the control when it's needed. So this patient presented with cough.
Okay, so this is a frontal chest radiograph of an adult patient. I can see that there is abnormality within the right hemithorax, and that's in the form of two cavitating mass lesions. They are in the mid zone on the right side. They have quite well-defined margins with quite thickened wall, perhaps with an air fluid level within both of them. No surrounding opacification that I can see. I'm just looking at the left hemithorax. It looks quite unremarkable to me. Looking at for any evidence of lymphadenopathy, I can't see any hilar or mediastinal lymphadenopathy, no pleural effusion, unremarkable cardiomediastinal contours. So in summary, adult patient with multiple cavitating lung lesions, there is no evidence of destructive bone lesion. So my first differential in an adult patient cavitating lung lesion would be of malignancy, would be more specifically of a squamous cell carcinoma. Other could it be like a metastatic carcinoma from perhaps a head and neck malignancy. Just looking at them, to me, could they be lung abscess? Would it be one of the differentials? If the patient is very unwell with fever, high infective inflammatory markers, they might represent lung abscess. However, just the multiplicity of them makes it a bit less likely. So I would like to correlate with the clinical history, infective inflammatory markers, and I would like to take this forward by performing a CT test for further evaluation.
Okay, I will let you have the scroll for this case. Okay. I think you have the scroll now, so you can click on the screen and start scrolling.
Okay.
Oh, no, just wait. Okay, just you can use the scroll.
Okay.
Scroll. No. Well, okay, can you use arrows up and down?
Yeah.
You have?
Yes, I
Yes.
am. Yeah.
This is yeah.
Okay.
Okay.
Presented with an axial uncontrasted CT of a child, and I'm just scrolling through the sequences of just the whole stack of the images. Okay, so I've noted that there is multiple abnormalities, and that's in the form of extensive intraventricular hemorrhage within both lateral ventricles as well as the third and fourth ventricle, with perhaps dilated ventricular system. Just looking, there are also some scattered parenchymal contusions. There is also a right frontal subgaleal hematoma that I can see. No evidence of midline shift that I can see, and no evidence of just trying to assess for any brain herniation syndrome. I can't see any cerebellar tonsillar herniation. However, in my normal practice, I'd like to check that on the sagittal sagittal images. So, I've also noted that there is a perhaps subgaleal swelling on the left frontoparietal region with underlying hemorrhage within the subdural region. I would like definitely to check bone window for any evidence of fractures. So in summary, there is extensive parenchymal / subdural hemorrhage with intraventricular extension with ventricular dilatation and secondary hydrocephalus. There are multiple subgaleal hematomas in different sites, and I'm highly suspicious of an underlying skull fracture. This is highly concerning. So I'd correlate with the clinical history, but this is highly concerning for a non-accidental injury. I would pick up the phone and urgently communicate my findings to the clinical team, in specific to the pediatric consultant. And this patient would require safeguarding referral as well as referral to the social services. This patient would require also a skeletal survey, looking for any evidence of skeletal injuries.
Okay, if the patient is in the in ICU after birth, and this is a subgaleal hematoma is related to birth trauma, so is this can change your screening checklist?
Yes, so if it is a neonate and that's shortly after delivery, and if the patient is a preterm infant, so I'd be suspecting that this is a germinal matrix hemorrhage, and that would be of a stage 4 with ventricular dilatation. I would also like to screen for any other evidence of prematurity disease. That would be of performing an MRI, looking for any evidence of hypoxic ischemic encephalopathy.
Thank you. This is another case.
Okay, so this this is an AP radiograph of a child, left side of a child. I've noted that there is a bone changes within the mid left humerus, and that's in the form of extensive sclerosis involving the diaphysis, with some periosteal reaction, as well as periosteal thickening more medially. It's there are some endothelial scalloping towards the superior margin of the lesion. I can't see any pathological fracture or any soft tissue component within it. I would like to check if there is any other view in my normal practice. I'll check for any evidence of other view, and that was taken. So, okay, on the other view, extensive sclerosis just confirms what I've seen on the previous view. and no pathological fracture. So it has quite a wide zone of transition. So I'm highly suspicious of an aggressive underlying bone lesion. My first differential for just checking for any other evidence of any other bone lesions. I can't see. The left hemithorax looks unremarkable. So my top differential for such a lesion in a child would be, could it be like an LCH, Langerhans-Cell histiocytosis? Other differentials, could it be more of, would be more of a sclerotic, so LCH, could it be like an osteomyelitis, chronic osteomyelitis, but I'd expect it to be more aggressive with more lucency, but it could be in the chronic phase, just presenting with sclerosis. So I'd like to correlate with the clinical history compared to previous images, if there is any previous images. And I would like to take this forward by performing an MRI for further evaluation of the bone lesion.
Okay, this patient, and you have a scroll, you can use it by arrows. This patient presented
Yeah.
with acute abdominal pain. Just click on the screen and subscribe. Yes.
Okay. Acute abdominal pain. Okay, so I'm provided with an scale CT abdomen, contrasted images in a patient who presented with abdominal pain. I can see that I'm just scrolling down the whole sequences. Okay, so I've noted that there is extensive free fluid within the perihepatic and pelvis, in keeping with a large volume ascites. And I'm just looking all the way down. Okay, so I've noted that there are a couple of abnormalities, large volume ascites. There is some bowel wall thickening. Small bowel loops are quite thickened with hypoenhancement of the wall. There is here within the area of the stomach. I'm just following so that's the stomach. Just noted there is bilateral pleural effusion more on the right side. So okay, so to me, mainly the abnormality is centered in the peripancreatic region with a large volume of free fluid collection. I can't see extensive stranding. I can't see any. There is hypoenhancement of the pancreatic tissue, so I'm suspecting that these features are in keeping with necrotizing pancreatitis. I would like to check the splenic vein, portal vein, and other vessels just for any evidence of thrombosis within them. Just checking. So the portal vein looks patent to me, as well as just checking for the splenic vein and SMV. So I can't see any evidence of thrombosis. Just looking down here, these bowel loops looks quite thickened. That might all be just reactive changes to secondary chemical peritonitis. So in summary, there is extensive features of peripancreatic fluid collection with non-enhancing pancreas. Features are highly concerning for a necrotizing pancreatitis. I would like to correlate with the clinical history. So if the patient is unwell with high amylase and infective inflammatory markers, this is highly supportive of my diagnosis. I would like to inform the team of these findings.
So, is there any specific requirement or specific interaction you need to ask the clinical team to start with?
So I would pick up the phone, inform them of these urgent findings, and I would like to perhaps maybe recommend maybe perhaps an IR opinion, just to see if they can drain this collection.
Okay. Okay, you can start this one.
Okay, so this is an AP radiograph of the left humerus, shoulder, and hemithorax in an adult patient. I can see that there are some extensive bony changes within the shoulder joint, and that's in the form of diffuse sclerosis. It is involving mainly the humeral head as well as the proximal humeral shaft. Just looking at and for any evidence. So to me, it looks like more of a diffuse sclerotic bony process that is ongoing. No pathological fracture that I can see. No pneumothorax. This left hemithorax looks unremarkable. So my main differential for a diffuse sclerotic process, a bony process, in a male patient, I'd be thinking of a malignancy, prostate malignancy would be my top differential. Other differential, if a female, it could be breast malignancy. So other differentials for diffuse sclerotic bony lesions in an adult patient, could the patient be sickler, but I'd expect some other manifestations of sickle cell disease, such as maybe cardiomegaly. However, I'm not seeing the whole heart and any evidence of avascular necrosis. So I would like to compare to previous images, if there is any previous images, and I would like, if the patient is an adult patient and they're suspecting.
Can you describe more the humeral head one pathology?
Okay, the humeral head pathology. So it's a diffuse sclerotic changes within the humeral head, scapula, as well as the ribs.
Okay, time. Thank you very much, Doctor. And now we'll move to the other room. You can take a couple of minutes to take a breath, and you can drink some water.
Okay, thank you.
Okay, thank you very much. And I will ask Dr. Fuad to come to the stage. Dr. Muhammad Fuad, are you here? Thank you. I'll make you a co-host. Dr.
Yes.
Fuad, how are you?
Fine, thanks.
Thank you very much. Okay, so
Can I share your screen?
yes, we'll ask you, Dr. Noha, are you ready?
Yes, I am ready.
Okay, you can, Doctor. Okay. I'll start the timer once you start.
Okay. Okay, this is a 70-year-old male with painful hip.
Okay, so this is an AP radiograph of the pelvis in a 70-year-old with painful hip. I'm just having a quick look. So I've noted that there is an avulsion fracture of the lesser trochanter on the left side. Just looking at the left hip, there are some lucency within the femoral neck, as well as the metadiaphysis of the femur with this avulsion fracture. Just looking again, so there is a bony fragment within the right anterior inferior iliac spine, again highly suspicious for an avulsion fracture. Looking for any evidence. So just I think there are multiple lucent lesions scattered over the bony pelvis. So in an adult patient with an avulsion fracture, this is highly suggestive of a pathological fracture. There are underlying lytic lesion within the bony pelvis, so I'm suspecting that there is evidence of metastatic bone disease. In the first instance would be an RCC in an adult patient. Other would be of a thyroid. So I would like to correlate with the clinical history and see if the patient is known to have any previous malignancy. And these are just secondary bony metastasis compared to previous images and see if that's already known or not. And if it's not known, I'd like to take this further by recommending a CT abdomen pelvis to look for any evidence of RCC, or an ultrasound of the thyroid just to look for any evidence of thyroid malignancy.
If this an metastatic lesion, can you expect the primary from this film?
So the primary, so these are lytic bone lesions. So the main primary, I'm thinking, could it be like a renal cell carcinoma? Would be one of my top differentials. Other differential would be a thyroid malignancy. In a male female.
Is there any clue in this film?
Is there any clue in this film? So there is a catheter in situ. I'm just yeah. Could it be like more of brown tumors as well? And patient has hyperparathyroidism, but I can't see any evidence of bone resorption or to suggest like brown tumors. From this film, I can't see that there is just an urinary catheter, perhaps a in situ, but I can't see any evidence.
Okay. This is another case of a 67-year-old female with abdominal distension.
Okay. So frontal radiograph of the abdomen in a elderly female. I've noted that there is a markedly dilated bowel loop within the left within the upper and mid abdomen, with furtherly dilated small bowel loops projecting over the right hemi-abdomen. Just looking, to me, it looks like it's so the apex of the dilated large bowel loop is pointing towards the left upper quadrant. Just looking for any evidence of pneumoperitoneum, which I'm not able to see, and no evidence of pneumatosis coli. However, in my normal practice, I'd like to check for like the lower pelvis. So to me, this is like an incomplete abdominal film. I'd like to look at the pelvis. But in summary, this is a dilated large bowel loop with evidence of small bowel obstruction. So I'm suspecting that this is in keeping with a volvulus. And to be more specific, I'm suspecting that this is more in keeping with a cecal volvulus. However, patient's age is a bit it's more common in young, but it still can happen. So I would like to take this further by performing a CT abdomen pelvis to assess for the volvulus and any evidence of complications from that, such as ischemia or pneumoperitoneum.
Okay, this is CT of the abdomen of the same patient. I'll give you the remote control. Okay, you can scroll now.
Okay, so I'm provided with a CT abdomen and pelvis in portal venous phase in the same patient that we've seen the radiograph, and I've just noted that there is a so I've noted that there is a dilated large bowel loop which is projecting just within the mid abdomen. It is definitely a large bowel loop, and I'm just looking at the small bowel just to check if there is any evidence of, and I can see that the transition point is within the lower mid abdomen. Just looking for any evidence, so I can see that there is evidence of I can see that there is some swirling as well. There is some dilated small bowel loops within the right upper abdomen. There is extensive free fluid in ascites. Just looking at the bowel loops, just checking for bowel wall enhancement. They look quite Normally enhancing to me. No evidence of nematosis intestinalis and no evidence of portal venous gas that I could see. So in summary, so this confirms, I'd just like to look at the cecum again. I'm just trying to work out if it's cecal or... So I can see the sigmoid sigmoid colon here down. I'm just following it up. Yeah, so in my normal practice, I'd like to check these in the coronal, but to me that looks like more of a...
No coronal. Okay.
Yeah. So I think it's more of a cecal volvulus.
Okay.
So I'd like to pick up the phone.
Is it a cecal volvulus? Okay. Is it a cecal volvulus? Can you tell me at which diameter the cecum will operate?
So it's 9 centimeter.
Beyond this, the cecum will perforate?
Like it's highly to, yes, cecum. Yes, it's 9, more than 9 centimeter.
Okay, let's take this. Okay, this is a neonate with abdominal distension.
Okay, so this is a frontal radiograph of the abdomen in a neonate who presented with abdominal distension. I can see that there are markedly dilated bowel loops within the upper and mid-abdomen. I can't see any gas within the pelvis, in specific no gas within the rectum. Just looking for any evidence of portal venous gas, like I can't see no pneumoperitoneum. There are lucencies within the bowel loops within the left upper quadrant. So in summary, a neonate with abdominal distension, markedly dilated small bowel loops. My first, with the lucencies, is highly suspicious for a necrotizing enterocolitis. No evidence of...
It's a full term baby, not a big term.
Okay, so a full-term baby. So my differential for a full-term baby with a dilated bowel loops, so would be more of a lower GI obstruction. So I'm suspecting, I'd like to know if the baby passed meconium within the first 24 hours, because I'm thinking, could that be a hair-sprung disease? Could it be more of an atresia, like more of a colonic atresia? In specific, would be... So I'm suspecting this mainly, my main differential is hair-sprung disease.
Okay, how to confirm? How to confirm?
I would like to do a lower GI enema, fluoroscopy study on this baby and look for the rectosigmoid ratio.
Hey, this is a large eye contrast study. What contrast you utilize in you?
Water soluble contrast.
Which concentration?
This concentration, I'm not sure.
Okay. Okay, proceed. This is the same patient.
Same patient, okay. So this is, lower GI contrast study. And I'm just looking, so the rectum looks normal in diameter when compared to the sigmoid colon. There is significantly dilated large bowel, mainly ascending. Mainly ascending, yeah. So ascending as well as perhaps maybe splenic flexure. and then there is a transitioning of the colonic diameter on the descending colon. So,
What about the diameter of the descending colon? Is it normal or not normal?
of the descending colon, it looks like it's descending. The descending, so the descending and the sigmoid looks quite small in size, like more of a perhaps microcolon.
Okay.
So I'm just trying to work out what would be the cause of such an appearance.
So that the transition at the splenic flexure.
So the
Okay.
so splenic
Thank you.
flexure is dilated as well. So it's the transition point is more down on the descending colon. Definitely sigmoid is small in diameter. So so I'm just trying to tie it all together, and so significantly dilated large colon. I can't take this case forward.
What about the splenic flexure? Examine it.
So the splenic flexure, okay, so splenic flexure looks dilated, with perhaps there is a filling defect within it.
Okay.
And this filling defect looks. So I'm thinking, could it be intussusception? But why would a neonate have an intussusception? It's not fitting. So I'm just going through my surgical sieve or the causes for such an appearance. So, so it's not a microcolon. So we've excluded Hertzsprung. We've excluded meconium alias and meconium plug syndrome because it would cause like a more of a microcolon. So this is a lower GI obstruction.
Okay.
Yeah, I'm stuck. I can't think of any other causes.
Okay. Let's take one. This is a 16-year-old female with recurrent fever and cough.
Recurrent fever and cough. Okay, so this is a frontal radiograph in an adult female patient. I'm just having a quick look. I can't see any obvious abnormality, so I'm just looking systematically, looking at the apices. I can't see any pneumothorax. Looking at the mid zones, so I've noted that there is perhaps an opacification, which is projecting more medially on the left lower lobe, or left lower zone, more medially, which is abutting the hard border. I'm just looking for any other evidence of nodules or masses, which I'm not seeing. I can see both breast shadows. Just assessing the hyla. They look normal to me. No more.
Sorry, time. Thank
Okay,
you,
okay.
Dr. Fuad, for that. Dr. Risk, are you here? I will.
Yes, I'm here. Yes.
Okay.
I cannot
will
share
allow
the
you-
screen.
Okay, wait. Just I will make you a co-host. You can share the screen now. So you can now start, and I will start the timer again. Okay. Go ahead.
So right now, this patient presented with abdominal pain. What do you think?
Okay, so frontal radiograph of an adult patient. I can see that there is homogeneous opacification just projecting within the left and mid-abdomen, displacing the bowel loops, perhaps maybe to the right side. I'm just looking the bowel, so there is paucity of bowel gas pattern elsewhere. So no pneumoperitoneum that I can see. So I'm suspecting that there is a large mass lesion within the left abdomen, upper abdomen, as well as the mid, and extending all the way inferiorly, displacing the bowel loop. So this mass lesion could be arising from the, however, I can't see the gastric bubble, like the whole stomach or the lower. I'm just trying to work out what could it be arising from. So could it be like more of a renal mass that is just displacing all the bowel loops to the other side, like a left-sided renal mass? Could it be the spleen? But again, I can't see the left upper quadrant very well. So I would like to correlate with the history. Why was the
And
X-ray
this patient presented with the acute abdominal pain.
acute abdominal pain? Okay, acute abdominal pain. So I would like to take this forward. So I can't see any evidence of bowel obstruction or pneumoperitoneum. So I'm suspecting that there is an underlying mass lesion which is displacing the bowel loops, and could it be have bled like a more of a retroperitoneal mass lesion? So I would like to take this forward by performing a CT for further evaluation.
What type of mass can this patient have as acute condition, do you think?
So I'm thinking, could it be like more of a retroperitoneal mass lesion, such as arising maybe from the kidney? Could it be like a large angiomyolipoma that bled, caused bleeding, and presented with acute abdomen, and it's just causing displacement? Other causes, could it be like more coming from the spleen? If it's a splenic, so patient had splenomegaly and ruptured the spleen, so presented acutely. So I'd like to know if the patient is hemodynamically stable or not. Although could it be more of a, so we've said the kidney, we've said the spleen. Could it be an adrenal mass lesion? Again, that just bled. So these are my top differentials. I'd like to take this forward by doing a CT, abdomen pelvis.
Do you have any other retroperitoneal structure that can bleed, that you think that's the common site for bleeding?
For bleeding, so if it's not the kidneys, could it be like more of a retroperitoneal? Could it be like an aneurysm, but the patient bones looks quite youngish to me? So could it be like more of an ruptured abdominal aortic aneurysm just coming from the retroperitoneal?
What you will do next for this patient?
So I would like to do a CT of the abdomen and pelvis to just evaluate this further.
This patient came, another patient who came to the ER with the acute leg pain, and they did for him this study. What do you think?
Okay, so this is a single image of the left femur, and I can see that there is a fracture displacement of the left mid femur, which is completely malaligned and displaced laterally. It looks more of a comminuted fracture. It is in the diaphysis. I'm just looking to see if there is any underlying bone lesion, but I can't see any underlying bone lesion. So in the context of trauma, so I'm suspecting that this is I'm just looking to see if there is any clue if this is a child or not, but I can't see. So in the context of trauma.
Why this patient, he is in the ER, the clinician note that this patient has deteriorated and his glaucoma scale is going down. So they did for him this selected images of CT. What do you think?
So is it just a single slice?
Yes.
Yeah, okay. So single slice, okay. So this is a single uncontrasted image of the brain, and I'm just having a quick look. So I can't see any hyperdensity to suggest any bleed. So I'm suspecting that given the fracture that there is an emboli, like more of a fat embolism that's just gone and occluded. But I'd expect that to be more to the lungs. So just looking.
So what do you think? What you'll do next for this patient?
So what I would do next, so I'd like to know if this patient is presented with a trauma that led to the fracture, as like a high velocity accident that the patient has been involved. Just looking at this slice of the brain, I think I've noted that there are hyperdensity within the left temple, so that might suggest.
So in that case, what you would like to do for this patient?
So in my normal practice, I'd like to scroll through the images just to check for any evidence of any abnormality.
And
But
if
I
you
would like,
don't find any abnormality, what you will do?
so if I'd like to check the basilar artery just for any evidence of thrombus. I'd like to take this forward by doing an MRI. Could that be part of a trauma and there is diffuse axonal injury?
So this patient did this study again, the same patient. So what do you think?
Okay, so this is a single slice and there are high signal within the centrum semi-ovale periventricular region. So I'm suspecting that there is evidence of so these are in keeping with bleeds. So this is GRE, so suspecting that this is diffuse axonal injury.
Okay.
So I'd like to pick up the phone, inform the team, inform them of the findings.
Okay. This patient came with chronic abdominal pain and he did this X-ray. What do you think?
Okay, chronic abdominal pain. Okay, so this is a PA rect chest radiograph of an adult patient who presented with acute abdominal pain. Just having a quick look. I can't see any obvious abnormality, but just going to go through my review areas and I'm just going to go systematically. I can't see any abnormality within the apices. Just looking at the lung bases, they look normal to me. Both lung volumes looks normal. Looking at the below the diaphragm, just given the chronicity of the pain. On the left side, I'm seeing this gas shadow on the left, but that could be just part of the gastric bubble. However, just the appearance of it looks a bit linear. Both hemidiaphragm looks normal to me. Just looking at the retrocardiac region, that looks normal as well.
What do you think the abdominal region, as you mentioned, what do you think below the diaphragm?
Below the diaphragm, so there is this lucency that I can see projecting over the left. It looks quite linear. So
What you will do next for this patient?
So I'd like to compare. So given the chronicity of the pain, I'm suspecting he had previous images. I'd compare to previous. And if there is no previous images, I'd like to take this forward by doing a CT abdomen.
Okay. What do you see?
So on that single slice, contrast CT abdomen, I can see that there is markedly thickened gastric wall. In my normal practice, I'd like to score to see if there is any evidence of obstruction, like if it's causing obstruction or not. But to me, and I'd like to assess for any lymphadenopathy. So I'm suspecting that this is in keeping with gastric malignancy, gastric adenocarcinoma or a lymphoma. So this is same patient. So same patient.
Which one you would like to think that could be the final diagnosis of this patient?
So I suspect, that I can't see any evidence of bowel obstruction here. So I'm suspecting that this is more of a lymphoma. Could have been lymphoma, just given that it's not
What
called.
do you do next for this patient?
So I'd like to refer this patient to the gastroenterology team for direct visualization with an endoscopy and a histopathology diagnosis.
Another patient came to the orthopedic for leg pain, and they did for him this X-ray. What do you think?
Okay, so this is a lateral radiograph of the knee in an adult patient. So there is, the bone looks, can't see any fracture. There is an irregularity within the cortex of the distal femur, and that's in the form of cortical irregularity with periosteal reaction. It looks like a wide zone of transition. No pathological fracture and no soft tissue component to it. It's more of a lytic lesion. More of a lytic lesion. Just looking for any evidence of any other bone
So
lesion.
what do you think about the differential in this case?
So this is in keeping with an aggressive bone lesion.
What you'd like to do next for this patient?
So aggressive lesion in an adult patient, I'm thinking, could it be metastasis would be one of my top differentials. Other, could it be like a primary bone tumor, such as an osteosarcoma? So I would like to take this further by performing an MRI of the whole femur and image the joint above and below.
So I will give you the slice where we can find the lesion. So this is the lesion here. So what do you think?
Okay, so on this specific slice, I can see that there is extensive abnormal signal, and that's in the form of high signal within the, that's within the tibia. I can't see any cortical breach. In my normal practice,
Yes.
yeah, so okay.
What you will do in your normal practice?
Okay, so in my normal practice, I'd like to check other sequence. I'd like to check T1 just to check for the bone marrow signal. I would
For
also
some
like,
reason, the hair clinician that did this
Mm.
study. What do you think?
Okay, so this is a nuclear medicine scan. This is a technetium-99 bone scan. This is a child, just given that I can see the growth plates, which are taking the which are just appearing quite hot and symmetrical bilateral. So just looking at the tibia, there is increased uptake within the right proximal tibia, just in addition to where the growth plate.
So in that case, what do you think? Do you have any other differential rather than malignancy?
So other differential rather than malignancy, could it be like more of an infective process, like more of an infection, like an osteomyelitis? That would be one of my differentials that correlate with the clinical history and the infective inflammatory markers. Other differentials, apart from metastasis, so it could be metastasis, primary bone tumor, or infection.
The same patient, you scroll through the system, you find this images. Do you have any other differential you can add for this case?
Okay, so same patient.
Yes.
Okay, so just okay, so there are some lucent lesion within the left iliac bone.
Yes.
So in a child, could it be like an LCH, Langerhans cell histiocytosis?
Also, you find in the system this X-ray in the hand.
Okay, so on this X-ray, I can see that there is well-defined lucency within the middle phalanx of the index finger. There are some erosive changes. So could it be part of like a hyperparathyroidism? Like this is a...
What do you do next for this patient?
So what I would do next, I would correlate with the history.
Okay. So the last patient, this presented with severe headache and visual. Okay.
Fine. Okay. How you feel, Doctora?
1 hour, yeah, of grilling. It's quite stressful, but it's just mimicking the exam, I guess.
Okay.
Mm.
And here is the important part of this one. Here is we start now the important part, which is your feedback about your performance, and this allow you to scope on the problems, the major one, not only the specific problems. Like I missed this one, I missed this one. One of the important issues in this activities to train with this similar appearance is to put yourself in the same situation of the exam. I noticed the hidden trick is happening with Doctor happened with Doctor Noha during the simulation. The performance start with the second half to go down. This is only due to exhaustion. He become exhausted because you need to practice long time, because your mentality, you got headache, you got from 1 hour of stress, so you start to drop. So you need to maintain the same level of practice along the whole hour, because may the examiner is hiding the tricky case to the last one. So this is a challenge in this situation. Now we'll start the feedback, and many thanks to Dr. Naha for sharing to be with us today in this whole hour. And we will hope, inshallah, we'll make a lot of these sessions for many colleagues asked for free activities like this one. And we'll start our feedback with Dr. Rizq, then Dr. Fuad, then Dr. Rihan, then I will be at the end. And many thanks for our colleagues, Dr. Rizq and Dr. Fuad, Dr. Rihan, for this one. Thank you very much. So you can start, Dr. Rizq, your feedback. Thank you.
Okay, thank you, Dr. Noha. Thank you so much for this introduction. You're very good, mashallah, very nice. Yes, this one is very tricky case. I show you this X-ray. Actually, this was a scanogram for CT. There is a fracture? Excellent. Then I think is good idea what you mentioned about the emboli. In the FLAIR images, usually maybe subtle. The good differential, you put the diffuse axonal injury. Usually you have to ask in your routine practice for the SWI or gradient echo. SWI more sensitive, especially for the foci of bleeds. In the cerebral emboli, it have very similar pattern as you see. Usually they present in diffusion restriction, and what you have to ask is for diffuse axonal injury for SWI, which have, as you see, blooming artifact. So this is a case of fat embolism, critical case. Excellent interpretation from you. When you find any major abnormality, you have to go through this abnormality and try to explain, especially when he gave you the history. So I see that you did it. So nice that you go through the lesion and try to interpret this lesion. And the good thing about lymphoma, as you know, that it causes thickening and dilatation in the same side. And it's usually active in the bit, in the FDG bit CT, as you see, and has highly metabolic activity. So this is a typical case of lymphoma, as you see, and you did it very well as well. So the third one was this one, which was in the acute status. He presented with abdominal pain, and there is widening of retroperitoneal shadow. There is also obscuring of the psoas shadow on both sides, but more in the left side, as you mentioned. If I am like to be the most safe, to mention the most critical one, I think if you agree with me, it will be the aortic cause. As you mentioned many causes, but lately you mentioned the aortic cause, which is the most critical one, as you see. this patient have hematoma and have aortic rupture, if you agree with me. So in this case, I think you, if you want to mention something about the acute status in this patient, which is involving the retroperitoneum, you have to go through the first critical one and the more safe for you and for the patient. Try to avoid any chronic causes, especially when he give you the history with such acute condition. You have to go through the acute status. In this case, I know that's very tricky, and but you did good. You try to interpret that this patient have many lesions. Everyone will think about malignancy, which is usual, but in this young age, we have to be broad-minded. This patient have some lytic lesions, as you saw. So in that case, we have to think about brown tumors, hyperbara. In the MRI, you will not, maybe just you can find that this patient have multiplicity again. But in the nuclear study, you can see that this patient have many spots of high tracer uptake that can help you to think about brown tumors as a usual interpretation. Also, from the hand, you can see that this patient have acro-osteolysis and he have lucent lesion, which again can help you to think about brown tumors. I think you did very well, and thank you for this contribution. And I wish to see you again, inshallah. And hopefully, inshallah, you can pass. It's very easy and safely, inshallah. Thank you so much.
Thank you.
Thank you, Dr. Rizq, for this quick one. Dr. Fuad, you can
Okay.
start your feedback. Thank you very much.
Okay, thank you, Dr. Noha. You are very good generally. In this case, you did it well. Your checklist is perfect and complete. This is a pathologic fracture at the lesser trochanter, and this is the lesion, lytic lesion. Differential include multiple myeloma and metastasis, but in this case, with urinary retention and 70-year-old male, you suggest or expect that the primary may be the prostate, and the secondaries here is lytic, not as commonly expected, sclerotic metastasis. In the second case, this is a large bowel, dilated large bowel, with some small bowel dilated here. This is a cecal volvulus. You did it well, but I trapped you in a question when I asked about the perforation. The risk of perforation in the cecum don't rely on the diameter of the cecum. Beyond 9 centimeters, the cecum will be dilated. But the perforation, the risk of perforation rely on the duration of symptoms. The answer you get it didn't correct, was not correct. In the CT, okay. This is not a sigmoid. You can see here the sigmoid is not dilated, show some diverticulosis, but no dilatation. And you can see here the swirl sign. If you trace this, you will get the ascending colon here. So this is a cecum, cecal volvulus, not a sigmoid. In the next case, okay, this is a neonate with abdominal distension. When you see multiple dilated loops, so this is a lower obstruction, not a proximal, distal bowel obstruction, not a proximal. The Hirschsprung and meconium ileus meconium syndrome are differential. The next step will be contrast enema. You can see here the rectus sigmoid ratio is normal, not reversed. So this is not Hirschsprung. The caliber here of the sigmoid and left colon is not normal. Could be a microcolon at the left colon only, and the transition here there is a filling defect. So this is a meconium black syndrome. Okay. The last case, there is an opacity here, paraspinal, and obscuring some of the hemidiaphragm, the medial aspect of the dome. In this case, with the recurrent fever and pneumonia, this could be a sequestration. Okay, this is the CT. You did well. I think you can pass very easy in the exam. Good luck, inshallah.
Someone is asking about the concentration of lower GI contrast in gastrographine.
Okay.
You asked this one and you trapped here there.
Okay. Not the concentration, but the osmolarity of the contrast. You should use not hyperosmolar and isoosmolar contrast, water soluble contrast. If you utilize gastrographene, you will dilute it with tap water ratio 5:1. 5 tap water to 1 gastrographene. So the osmolarity will be about 300. Okay.
Slightly hyper, yeah. Slightly hyper.
Yes.
Yes. Okay, so don't use barium in this because you'll kill the patient.
No barium.
Definitely.
No.
Okay, so this is a very risky question. Thank you very much, Dr. Fouad, for this quick feedback. And I will ask Dr. Rihan to come again, take the mic.
Okay, hello.
Hello.
Okay,
Go ahead.
start my cases, yes. Okay, let's go with it. Our first case was this. First of all, I would like to thank you for your amazing level actually in radiology. You did more than just perfect. So I will just try to highlight for the things that you did that perfect and ask you just to a fine refinement, if ever. In this case, you did very well, actually. Yes, I was so impressed with the gas, the portal venous gas. I was so impressed with the dilatation and the areas of calcification. This is ideal, but you just was a little bit hesitated about this calcification, but okay, it's fine. Of course, you did it perfectly. You said straightforward, a golden ileus. With all the required findings, but you told me that there is no pneumoperitoneum. I still can't tell adequately if there is a pneumoperitoneum or not because the view is not that full. This is not the ideal view, so you are supposed to ask for a better view to include the diaphragm because this is inadequate view. That's all about this case, and of course you did after this more than perfect. You will call the surgery and this is an emergency case and so on. Okay, this was perfect, thank you. So don't forget to ask about a perfect image rather than this. It doesn't include the hernial outlets and it doesn't include the diaphragm, so I can't check the abdomen fully on these images. This was the first case. The second case, yes, perfectly. There is a dense or an opaque structure that is related to the right ilia fossa, and it is likely a migrated IUCD. Yes, you said it perfect, but you was a little bit hesitated. Yes, it is a perforated IUCD. I would just correlate with the medical history for the patient and would go further. If she's present, I would go further with an ultrasound assessment for is it still in situ or not, and ask the patient about her medical history. That's all that we need to do. But or every other things that you have just stated was just more than perfect. This is another case, and don't forget to tell me either there is a pneumoperitoneum or no in this case because of the perforation, whatever. This case, you was just distracted by meaning of the sternotomy sutures, but the mean pathology is on the right side. But apart from the main pathology, I was just impressed with your strong character, and yes, they need someone with such a strong character who are so self-confident. Yes, so chapeau for this character. But if they ask you to recheck a certain place, just go with them. They are leading you to the correct answer. So here I just tried to lead you to check the right side because the pathology is notably on the right side rather than the left. This right side is rather hyperlucent. There is overcrowding of the ribs over here. This case is a Poland syndrome. So it would be in a differential diagnosis for a hyperlucency hemithorax. And we have even the CT if you would like to check it before the operation. So don't get distracted with a finding. And when they guide you to any other abnormality, just go with them and check it because they mean it. Okay. Just the list of the differential diagnosis for a Poland syndrome. No, okay. Just this is position, and there's nothing with this veiling. There is nothing as long as the cardiophrenic angle is just clear. That clear. There is nothing with it. This is a masking. It appears like there is something here because this is a hyperlucent. The abnormality is notably on the right. There is blood vessels here. There is kind of nothing here. You have first to identify what is a hyperlucent. First, you have to assess where is the pathology, the main pathology. How can I check in the chest? Is it the problem with the hyperlucency or an opacity? Is the hilum and the engorgement of the vessel? This is normal hilum and normal appearing vessels. Here, likely there I can see most of the vessels, and the hilum a little bit. Yes, it is well defined. So I'm going with where is the lesion. It is related to an area where I can see the normal blood vessels appearance. This is the normal and this is the abnormal. So this was a Poland syndrome. In the woman imaging, you was just perfect. And I would like other colleagues just to take it from you as a message. Yes, once they bring you a craniocaudal, ask for the mediolateral oblique. This is very important. One view is not sufficient enough. Yes, this is called the outer quadrant, and this is the inner quadrant. And in the mediolateral oblique, it is the upper and lower. And don't forget to mention that you will use the zoom lens in order to check the pattern of the calcification that is related to the area of this asymmetry that is being present on the left breast. This is very important to tell them about this zooming imaging and the lens in order to check the calcification. And also here, the both breasts have macro calcifications. You have to check it also with the zooming lenses. This is number 2. Number 3, you did it more than perfect when you told me that she has to go further for an ultrasound. And fine needle. Don't wait me to ask for it because this is called a triple assessment. And after you say I will go for ultrasound and ask for a true cut biopsy to fulfill the triple assessment criteria. In case the examiner haven't told you about the age of the patient, this patient was 40 years and I meant the age. Just to tell you that it wasn't a screening. If I told you that the patient was a 50 years of age and plus, don't forget to tell me if she was in a screening program, I would call her in order to continue her assessment. And if she was not, this was our case, okay? So don't forget to focus or to concentrate with the age of the patient, especially the females, for the screening program. They don't tell usually either she was a screening program or not. So don't forget to call her and ask her to come to continue her checks. This was for the breast imaging. And there was a case here for, you did it perfect and you was likely to pick it up and it was so easy for you, but I don't know why you disregarded your finding. Yes, here there is a posterior fossa that is being so prominent, fourth ventricle that is also a little bit dilated, but not that much, and all this hydrocephalus. And don't forget, once you see a hydrocephalus, tell me that this is an emergency case, and I have to ask the surgeons about this hydrocephalus. This is very important in cases with hydrocephalus, even if I didn't pick the codes for this hydrocephalus. This is number one. Number two, yes, I haven't found any lesions here. There is no need for the contrast images. I would ask for CSF flow if I can't find any other further pathologies. You asked for the sagittal, and this was amazing. Don't forget ever to ask about the sagittal. It tells you a lot, especially in the cases for the 2B in the neuro, if there is not hemorrhage. And in here, the lower, the inferior lobe of the cerebellum is likely hypoplastic or agenesis. Also, the verms is likely hypoplastic a little bit. Yes, the posterior fossa is prominent, and here also the fourth ventricle. So the cause of the hydrocephalus was an Andy Walker variant. Don't forget to put it in your differential diagnosis. Once there is a hydrocephalus in children, it is either hemorrhage, it is either meningitis, lesion, and then the Walker and its variant. That's it. You did more than perfect, and I'm so proud to have you today. Thanks. Thank you very much. And good luck.
Thank you.
Thank you, Dr. Riham, for this amazing feedback. I want to start from I'll take the words from Dr. Riham and start talking with you, Dr. Noha. And here I want also to announce some important issues and tips for all candidates. In most cases, as an example, it's important to have an approach. You once you pick that the patient have a hydrocephalus, so you start to analyze this one. So you need to announce it's an obstructive communicating or non-communicating one. You need to ask what is the level? It's supratentorial or at which level? So then when you start like this one, so you put some differential in the trash. So like aqueduct stenosis, when you have a dilated aqueduct itself, and there is dilated also fourth ventricle, so you will put all this in the trash. So you will not mention this as a differential diagnosis from the start. So that's why what I mean in my presentation in the beginning, you need to have an approach. Okay, similar case, you must have some kind of this one. And one advice I mentioned also in the presentation regarding the case of the Dr. Mahmoud Risk about you must put the what is the emergency in this case? What is the most important emergency topic in this case? In the case of the aortic aneurysm, and start with this one. Okay, so you must highlight all these things when you are preparing preparing for the FRCR to be vivacious. I'll start my cases, and you did amazing with me. In this case, I can see that the marked sclerosis, if you can see, I start with the last case you did at that time, and we finished after this one. It's similar to, it looks likely to represent an ice cap here, so it's a vascular necrosis, and I think there is some red notching here, some in the plate, slight H shape, especially in this one with diffuse sclerosis, so secular. You mentioned this that you excluded from your differential diagnosis, but you did very well. You mentioned all. You need to go more for the clinical data of the patient. You need to go more for any previous imaging, because sometimes the examiner will have other images with more prominent features, but he need you to go on the track and raise the possibility and follow it. Okay, So you did nicely, no problem. In this case of aggressive wound lesion, you did it very nicely, and you mentioned and described it very well, and your approach also very nicely. So I have no comments on this one to be considered. In the case of this one, of this IVH grade 4, you need to use F, the magic F. Okay, so because this, it seems to be a unit, and you need to use an F. But to start with non-accidental injury as differential diagnosis is very important, and you did very nicely by asking to check the bone window. When I redirect you with the clinical data, which I hold in the beginning to see your approach and to see your, so you need to describe the criteria, and you did it very nicely. So the patient have diffuse brain edema, and the patient starting to have hallucinations around the periventricular region. So the patient may have hypoxic ischemic encephalopathy as well. So this was grade 4 IVH with dilated ventricles, and even the bleeding is reaching everywhere in the ventricular system, and also invading to soft tissue of the brain parenchyma. So you did this also very well. This case, this is a common scenario in the exam, that the examiner will bring a case of differential diagnosis, and in this case, he needs you to use your knowledge and your experience to analyze this one. So you did this very perfectly. You mentioned this could be a metastasis. You can use the negatives and other positives if present in the case, to analyze more and narrow the differential diagnosis as you can. You can use the clinical data by using magic F in the patient, as you did. The patient is feverish and unwell. I will consider septic imply. I will consider I will consider other lung abscess. I will consider maybe if there is any other features, nodularity, or consider TB. Also, another features could be squamous cell carcinoma metastasis, one of the important differential diagnoses you mentioned. This one, the necrotizing enterocolitis, is the only necrotizing pancreatitis. This is a very aggressive lesion, and there are multiple abnormalities, and you picked most of them. So don't forget to go through this very quick and analyze it, and collect the data together to reach a final diagnosis. You mentioned the collection, and you need to mention the need of the of intervention and the urgent intervention if it's the situation in your case. In any case, I am talking in general. So you need to go through this and tell the examiner, and don't wait the examiner to ask, because sometimes examiner will not ask and not take any action, and his action will be on the papers. So don't let the examiner, don't suppose that the examiner is satisfied with your answer. No, keep looking, keep talking about what you are going to do, about your checklist in a systematic manner. And generally, with me and with our other colleagues, I think you did very well. Thank you very much for that. But you need to keep practicing, keep watching, try to analyze and put the and study and prepare. You all study with differential diagnosis approach. Differential diagnosis approach. You collect the findings and you see what is the differential of these findings. So you start to make the negative and positives again in the second round. Then you go to narrow the differential diagnosis, and then you'll found the final diagnosis correctly from the first, or you need further investigation or further modalities or further sequences, whatever the situation is. So you'll start to narrow the differential diagnosis using this. Remember the emergency cases every time. Remember to announce you are afraid from any emergency in this case, so you are going to tell the team, are going to pick the phone, change your body and your voice tone when you're facing such serious. Let the examiner know that you know this is an emergency and give him this all this practice and practice and practice is the only way to pass the RCR to be exam. So keep doing it. You'll fight, inshallah, until you pass. Thank you very much, all. This lecture will be recorded, is recorded. Yes, I think someone is asking about sickle cell. Yes, it's case of sickle cell, and I have other films for it, but I hold them. So by the end, I want to thank Dr. Anoha very many thanks, and also I want to thank all the examiners, Dr. Rihan, Dr. Muhammad Fuad, Dr. Rizq. Thank you all, and thank you, Dr. Anoha. And I hope you can give us also a feedback about this activity on the Telegram or privately, and then we'll meet inshallah in another events soon. Keep just in touch with us on our group, and I want to ask also let you know that we have still spaces and drive Viva with Radmi. If you are going to share this with your colleagues, it will be amazing. Thank you very much, and meet you again. Thank you.